It is.
Okay. Well, welcome everyone. I just told Jenny I'm not bashful, so I'm going to just introduce myself. My name is Nirmala Dahr, and I work for Oregon Health Authority, and I work in the Health Systems Division on the Adult Behavioral Health team. And I am the project director for an initiative called the Older Adult Behavioral Health Initiative. And here is your Older Adult Behavioral Health Coordinator for the North Coast. A part of our function through this initiative is to do what we call workforce development. And with that in mind, I'm here today to give this training on suicide in older adults, risk assessment and prevention. I'm a licensed clinical social worker by profession with 35 years experience in behavioral health in the public sector in 4 states. And for the last 20 years before moving to Oregon Health Authority, I worked for Clackamas County Behavioral Health. So I worked in the trenches, I worked as a manager, I worked as a policy analyst. So I kind of feel your pain. I know the multiple hats you have to wear, especially in areas which are kind of rural or semi-rural and professional shortage areas, which we are going to which play a very critical role in risk assessment for older adults. So I'm delighted to be here, and thank you for inviting me to speak. Ellie, do you need to say anything about signing in and all of that?
Probably.
Yep. And then I'm going to ask them to please. You can introduce yourself. Okay.
I'm Ailey Ray. I work for Gobi, but it's a statewide initiative, so I'm still in the area. I live in Gerhardt, Oregon, actually, so I'm a local. I do have class at Columbia and Tillamook counties, but, you know, I'm here. There is a sign-up sheet for CEUs for after, if you guys could do that now, or I can pass it around if you didn't get to it. And then I'll email the CEUs out to you. And thank you.
And also a certificate of attendance.
Yeah, and a certificate of attendance. And you'll also get an email with like the evaluation for our presenter, who is lovely and thankful that she's here today, long travels. And if you could fill that out, it really helps us going forward with trainings and whatnot, just to kind of know how we're doing. Thank you.
And that will be sent electronically by Portland State University. So if you see it, don't put it in your trash. We'd really appreciate if you take 5 minutes to complete it. So I'd love to know who is in the audience, and if you could just very quickly, if you could just give me your name and what your role is wherever you work, that will help me customize my presentation just a little bit. I can't promise that I will remember everyone's names, but it will just help me understand who's in the audience. I'm wondering if you'd like to start.
My name is Alice. I work for Classic Behavioral Health. I'm a case manager with the ACT.
I'm Jen. I'm the nurse with Classic Behavioral Health Care. I'm at the ACT team in Forensic Center.
I'm Jenny Rizzi, and I am a peer support specialist for the ACT team for CDH.
Michael Diamond, and I'm a case manager with the ACT team in the CSS program.
Okay, so here's the ACT team. Got it. Can we go here?
I'm Lynn with Northwest Senior and Disability Services. I lead the eligibility page.
And I'm Suzanne Yarmson with Northwestern Disability Services, and I do the community program supervisor, so pretty much the older American Act programs and bringing information to the community.
I'm Megan. I'm with Northwest Senior and Disability Services.
And I'm Rick Martinez, I work for Classic Behavioral Health, and I'm the assistant treatment counselor.
Rose Anderson, I'm Classic Behavioral Health, and I'm a recovery hour impairment.
I'm Sheldon Silo, also a licensed clinical social worker at IBC, geriatric sciences, and
I'm Jim Holden. I'm a crisis team worker with CDH.
Aaron Jones, I'm a crisis manager with CDH.
My name is Martina Wonke. I also work at Classic Behavioral Health Care, and I do mental health counseling for adults.
Clarissa Flores, I work with Classic Behavioral Health Care, and I'm an exceptional care coordinator.
Jenny Robinson, I work for
CCH, and I'm Clinical Operations. Shira Merla, CBH Director of Outpatient Services.
Hi, Dave Shaw, Program Manager.
Hi, Dave. Thank you again.
No problem.
Nicole Downs, also for CBH and work in the adult outpatient team for substance use.
Okay. And then, do you want to just introduce yourself, Tim? Okay, go ahead.
Well, I'm Ben Paz.
Oh, hi, Ben.
Supervise the crisis team.
And I'm Michael Shipley, I do communications and quality metrics for CBH.
Okay, well, thank you all for coming. How many of you regularly do suicide risk assessments in your various roles and settings? Okay, so like 5 or 6, okay. So, oh hi, oh I'm so sorry, who's on the phone? Hi Marianne, this is Nirmala.
Hi there.
Anyone else on the phone?
Yes, you have 35 Interpersonal as well.
Okay. Any more?
I don't think there's anybody else on the phone. You
Oh.
guys have all the handouts or whatnot, right?
Okay. So my topic, and do you know what is the month of September has a special designation this year? It is Suicide Prevention Awareness Month. And so this topic really aligns really well with that, and so I'm very happy to be here. My topic is really suicide in older adults. And we're going to look at what are some key differences in older adults and younger adults in terms of risk and assessment. And so I'm going to cover what are the risk factors, what are some evidence-based assessment tools, which I think Ailey was passing around to you. We'll talk about that. And very important, what can you do as Clatsop Healthcare and other community partners, what can you do in terms of prevention? Ailey, I just realized you would have to move it because I'm up here.
Either that or I can figure out how to give it to you if you want to.
Okay, whichever. I need to move it to the next slide.
Well, I'll do that and then I'll.
Yes. So here are my, I'm not going, you all have the handouts, I'm not going to go over every objective, but really one of the main reasons I'm giving this talk is to increase knowledge about the causes of suicide among older adults. And then really look at how to assess and find help for those at risk. So those are some of the key objectives, but you have the rest too. So with that, let's just move forward because I have a lot of material to cover. Yes, you can just move it. So do you know worldwide how many people commit suicide worldwide? Anyone wants to take a guess? It was just, this report was just published by World Health Organization. Anyone just wants to throw out a number? I'm talking about worldwide. 800,000. 800,000, little short of 1 million people. And so, and what the report said was that other countries have higher numbers of people, but United States has a higher rate. So, and we calculate rate per 100,000. So we have a higher rate of suicide, but worldwide 800,000 people. So here are some suicide facts for you. In the United States, 10th leading cause of death overall. More than traffic deaths and twice as many as homicides is suicide. So it's in the top 10 killers. What's the number one killer of people in the United States? What?
Heart disease.
Yes. A second is cancer. 10th is suicide. It is the third leading cause of death for those 15 to 24 years old. Look at it, in 2017, 47,000 Americans died by suicide. And that was died, look at it, 1.4 million attempted suicide. In 2014, 20 veterans died each day. And 6 of the 20 were users of VA services. That they were connected in some way to a healthcare system. And overall, 18% of all suicides are from our veterans here. In 2000, 65% of all veterans who died by suicide were 50 years or older. So it's not the really young veterans, you know, who are actually, dying by suicide. You look at it, more than half are older. How many, do you all work with veterans at, so that should, why am I giving these data? Because that's a risk factor. Older veterans should be screened. Ideation and attempts are very high in women, but look at mortality higher in men. Why do you think so? Yes.
Lethality means usually, actually, we were talking about this at one point in other training, and they mentioned that men are more likely to be like, I don't really care what I look like at the end, so whatever I'm done, I can make it a mess. Whereas women are like, I want to look good.
So yes, men use more lethal means. So men are using more lethal means like guns. And women are still using poison as in medications. So they attempt at much higher numbers and have higher ideation, but men have higher, and there are many other reasons aside from lethality, and I will talk about it. Look at it, in 2017, firearms accounted for more than half of all suicides they used a firearm. Okay, that's the next one. I'm just giving you the suicide rates. The light gray is female and the dark is male. What does it tell you? Every age group, there's a gender gap, right? There's a gender disparity. Can you see? Males are dying by suicide in every age group at higher numbers than women. Look at, say, age 35 to 44. 8% women, 27% men. So there's more than just firearms here, and we'll talk about it. So this is something for you to look at later, and that's the rate I was telling you per 100,000. All around the world, they have more numbers of people dying by suicide, but in the United States, we have a higher rate of suicide. How do I do this? Oh, no. Next. Okay. So this is by age, race, and gender. The gray is white males. The pinkish color, it went forward. I need to be on the other slide. The pinkish color is black males, then it's white females, and then black females. Who is at the highest risk in terms of race and gender? White males. Why do you think black females what could be some possible explanations for black females having the lowest suicide rate? And also look at black males are in pink, compare it to the gray area. What do you think are some possible explanations?
I think that African American women, when they're young, they are female, they're people of color, and if they make it, they don't have a lot of power not as individually, but statistically. And if they make it to become a matriarch, they get to be a matriarch sometimes of a large extended family, and along the way they have accepted the fact that life includes pain, unlike some white women or white men. White men start off being privileged from the beginning just by being white and male, and then before death they all have to face ageism, and they probably are making less money, they probably lost powerful status in the community, and lots of, but finally, they're going downhill, and they have the guns.
Yes, so many of the reasons which you alluded to, but African American women and also men, they have larger kinship networks, greater sense of community and connectedness. Many of them belong to strong faith communities. All of those contribute to lower prevalence of suicide, even though they may have had some hard knocks and disparities, but those are the protective factors, and we're going to talk about them. Yes. Look at the suicide rate in your county by age. Clatsop County had overall, you know, if you look by age, and this is for those years, your rate was 28.7%. And the state of Oregon, the rate is 25. So you have a higher rate of suicide in your county than the rest of Oregon. And I just compared it to Tillamook. Tillamook is lower than your county and lower than the state's. But you can see by age too. So I have just broken it down, and I've given my citation there. You can get a lot more data if you go there and look it up, okay? Yes. So here are the highlights. Late life suicide receives less attention than younger ages. And that is true in Oregon too. I work for Oregon Health Authority. You know, a lot of our efforts are very youth focused. In suicide prevention and in other things too. So late life suicide gets less priority. Internalized ageist stereotypes are associated with reduced will to live. How many of you have seen or heard these kind of ageist remarks, ageist stereotypes? They actually, there's a researcher at Yale who studies that, and she said it actually decreases life expectancy of older adults. Cognitive control is a contributing risk factor. One promising prevention strategy is high-quality geriatric medicine. Duh, we know that. I was at another meeting, at your workplace, and we said there is one primary care physician for every one primary care physician sees 1,300 patients. That's the ratio. And they may not be geriatricians. Addressing ageism as a universal prevention strategy is essential. And we'll talk about some strategies. Look at suicide deaths by methods. Firearms. Suffocation, which includes hanging. Poisoning is generally medications. And then there's other. You know, it's different in many other countries, especially in Asia, where the gender gap is less. And do you know what? They mostly die by poisoning, and that is fertilizer. They ingest fertilizer. And India is considered one of the capitals of suicide capital of the world. And what they found was many of the younger people were using rat poison to kill themselves. And so much so that it rose to a public health level. And the Indian government then mandated the industries that created rat poison to remove whatever the toxic substance was that killed humans and use something else for killing the rats. And do you know what happened when they made that change? Suicide rates plummeted. So it's true, when you limit the means, like guns, suicide rates fall. And they've seen it with other substances. Next one. I'm going to let you look at this yourselves later. I know it may be very tiny in your handout, but I have a citation there. If anyone is interested, I can email it to you, just for time's sake. Yes, next one. Suicide deaths are a major component of the opioid crisis. How many of you are involved with anything with the opioid crisis here in your county? I know I heard Matt and some Act, all of that. Look at it. 47,000 people died from overdoses. Concealed in this number is a significant number who decided to take their own life. We don't know whether it was accidental or it was actually a suicide attempt. So it's concealed. Some experts say that 30% of those people who died of opioid overdoses may fit this description of that they were actually, it was a suicide. So it was intentional. National statistics increases in suicide involving opioids among all age groups except young adults between, so except for teens and young adults, all age groups have seen an increase in suicide involving opioids. So I just wanted to put in this slide about opioids, next one. So what I want to convey today is that we often hear this comment, which is ageist. Of course they want to die, they're old. I would want to die too when I'm that age. That's an ageist, ageism, like very, very explicit ageism. Suicide is not a normative response to the challenges of aging, and suicide prevention efforts can reduce suffering and prevent death among older adults. Next one. So what's the significance? Older adults are the most rapidly growing segment of the population. In a short 10 years, which is not too far away, 20% of the United States population will be older adults. You guys are already at almost 23%. So can you imagine in 10 years, you'll probably be at 25%, which would be 1 in 4 people living in Clatsop County will be an older adult. So it is the fastest growing population. Oh, no, I'm not finished. Older adults have higher rates of suicide than any other segment in the population, especially white males. Suicidal behavior is more lethal in later life than in younger adults. So that's significant. We're going to talk about it. Next one. Why is it lethal in older age? Look at it. They are more frail, so more likely to die or less able to recover from the attempt, just because they are physically frail. More isolated, so less likely to be rescued. And then more planful and determined, so there's decreased expression of ideation. That means they keep it secret, they plan it, and they do it. So there's less ambivalence. And those are key differences in older adults. Yes. So this framework has really helped me a lot. It's called the 4 Ds of older adult suicide. Look at it. Depression, debility, which would be some kind of disability, disconnectedness, which is isolation and loneliness. And lastly, deadly means, that they have the availability of deadly means. So if there's one take-home message for you to kind of keep it in your head, it would be this framework, the 4 Ds of suicide for older adults. So it's depression, debility, disconnectedness, and deadly means. Okay. So lethality. Remember we talked, that's one reason why older white males die at such high rates is because they use very lethal means. Older adults are twice as likely to use firearms as a means of suicide than are people under age 60. Remember I said less ambivalence and access to lethal means. Lethality of older adult suicide suggests that interventions must be aggressive and that multiple prevention methods should be used. Just because it is so lethal, and I told you all the other reasons, frailty, social isolation, that once you know someone is having any ideation, the response should be aggressive. Okay. Here are the risk factors. Depression. Did you know that in younger adults, when they do a postmortem of the data, 50% had no psychiatric diagnosis. 50% of younger adults who completed suicide, there was no mental health diagnosis. But here, it's right on top. Depression is a risk factor in older adults. Prior suicide attempts. Comorbid medical conditions, and we're going to talk a lot about that. Pain and role function decline. That you're not mobile anymore, so you can't walk, you can't drive. You're dependent on care for bathing or showering or toileting, so decline in function. You're dependent and or isolated. Family discord or losses. Personality traits where you're inflexible. And you have very rigid coping skills. It has to be my way or it's the end of the world. I won't accept it. And what happens when you're older? There are multiple transitions, right? Retirement, loss of loved ones or spouse, maybe moving to a retirement community or a nursing facility. What do you need to do? You need to be fairly flexible, right? And be able to cope. So if you have a personality style which is rigid and inflexible, how do you think you're going to fare? It'll just exacerbate any kind of low-grade depression you may have, right? Lastly, access to lethal means, which is essentially guns. Next. Look at psychiatric illness. It was present in almost 97% of older adults who committed suicide. Remember I said in younger adults, 50% did not have a mental health diagnosis. But look at this, almost everyone had a psychiatric illness. And the most common was affective disorders, and of those, major depression, most closely associated with suicide. Earlier, when I was meeting with some of your managers, they talked about you all see older adults. How many of you all routinely screen older adults for depression? That's part of your, part of your assessment. If there's one take-home message, it's this, that for suicide, 97% have a major depression, and it is correlated with suicide, or I would even say causal. Yes. Look at, so that was psychiatric. Look at medical and medical comorbidity. In younger adults, substance abuse and personality disorders are very common, what we call co-occurring diagnoses with, say, a mental health issue. Look at in older adults. Comorbidity is characterized by concurrent mental and physical illness with cardiovascular and cerebrovascular disease playing a prominent role. So heart conditions, strokes, all of them, they're comorbid with any other mental health condition in older adults. So as an individual's acute and chronic condition increases, that means physical conditions, so does the risk for suicide. So if you have one chronic health condition, or if you have three, the person with the three chronic health conditions is going to be at a much higher risk for suicide. Beyond number, look at the second point is really salient. Beyond number of physical illnesses, the perceived meaning of the illness, their impact on your functioning. Does it limit your functioning? Does it really change your identity? Pain, threats to autonomy and personal integrity play pivotal roles in suicidal ideation and suicide in older adults. So it's not just the illnesses, the cumulative effect of multiple illnesses, it's also what meaning you give to those illnesses. That it's no longer me, it's changed my identity, I'm dependent, I've lost my autonomy, my sense of agency, all of that. Association between severe pain and suicide was stronger among men than women. Why do you think so? That means if there was severe pain, the suicide pain connection was stronger among men than women. Men are what? Men are?
Nigel.
I didn't hear that.
Men are weaker
No, men don't have help-seeking behavior. And they adhere to these very strong social scripts that, you never ask for help, you should take care of yourself, you should be self-reliant, which also goes for depression. And actually help-seeking behavior is a protective factor. And who seeks help? Women. There's a gender disparity in health-seeking behavior. Next one. So risk factors that increase risk for suicide: functional impairment. You can't bathe, you can't toilet yourself, someone has to feed you, someone has to dress you, someone has to drive you. Pain, disfigurement, whether it is perceived or real, you have tubes running in and out of you. Increased dependence on others, that you have to depend on someone for your care. Decreases in sight, that means vision and hearing. And risk for suicide associated with medical, but all of this is always mediated by psychiatric symptoms. Most common, I told you, is major depression. Yes. By the way, this is not only for older adults. Risk of suicide in persons with physical illnesses. Guess what? The top two are AIDS and epilepsy. So it becomes critical if you are seeing a client with seizure disorder, whatever age, they are at very high risk for suicide. You wouldn't think so, right? But it is true. And then all the others, brain injury, Huntington's disease, cancer. But I was shocked. Epilepsy is absolutely something that you should consider as a risk factor. Okay. So now, social factors. They play a role in both, a very critical role in prevention of suicide and also a risk factor. Two broad categories. One is stressful life events as predisposing factors. It could be loss of a spouse, retirement. It could be, you have lost your mobility. It could be any number of things. Social connectedness as a buffer that serves to reduce suicide risk. How many of you screen your older clients for social isolation and loneliness? Do you know it's one of the biggest risk factors for suicide, dementia, depression? And there is a fabulous tool, it's the UCLA Loneliness Scale, which through our initiative we are promoting. It is one of the biggest risk factors in suicide for older adults is social isolation and loneliness. And I would certainly encourage, those of you who work with older adults through APD and AAA to make that part of your screening. Are you lonely or do you feel isolated, you don't have any, and the UCLA scale is a really good scale to use. Next one. Stressful life events preceding suicide tend to be more severe and numerous among suicides than controls. So when they did a study, people who committed suicide had many more severe stressful events than controls, that people who did not commit suicide. So, and then events most salient to late life suicide, look at it. Threats associated with ill health and functional impairment, loss through bereavement or ruptured family relationships, and other sources of support. Those were some of the most prominent reasons for suicidal ideation. So social connectedness is so important that the CDC has identified, the Center for Disease Control has identified it as a key strategy for preventing suicidal behavior at all ages. The promotion and connection of and strengthening of connectedness at family, personal, family, and community levels. Remember we talked about why do African American women have such low levels of suicide, and also men for that matter compared to white men? It's because they are socially, they are much more socially connected to their communities than others. Older adults who completed suicide were less likely to have a confidant, more likely to live alone than their peers, less likely to participate in community activities or be active in an organization or have a hobby. So you actually have a prescription of how to promote social connections. Can you provide this for your older adults? Having a greater number of friends and relatives in whom that you can confide was associated with reduced risk of suicide. These are like simple interventions to encourage that. So how many of you have heard of Thomas Joyner? Okay. He's a leading suicidologist. He's a researcher. And this is his theory of suicide. And if you ever get to hear him, you should. He's a fantastic speaker. And his father committed suicide, and that's what catapulted him into this area of research. So he brings a very personal story to his work. And this is his theory of suicide. It's called the Interpersonal Theory of Suicide, and I would encourage you to Google his work and read more about it. And I have a citation, I have his book there, Why People Die by Suicide. So he talks about these three things having to come together. One is thwarted belongingness. I'm alone. Perceived burdensomeness. I'm a burden to others. And then capability for suicide. I'm not afraid to die. And can you see that intersection of circle? Desire for suicide. What he says is all of these three have to come together for someone to move to the next step, to actually contemplate and then take their life, because by default, what are we built to do as humans? Self-preservation, right? So you have to go against that instinct for self-preservation. And so he says these things have to be present, that sense of I don't belong, I'm a burden, and then I'm not afraid to die. Sometimes you may have those two but not have that you're still afraid, which can actually be a protective factor. We will see how religious and cultural themes actually protect you against suicide. But his theory is essentially all of these have to be present for you to actually complete a suicide, and it's called the Interpersonal Theory of Suicide. Just the next slide. And here is some other researchers. They are from the University of Rochester. They took his interpersonal theory of suicide and then applied it to late life suicide. And you can see all the things that have impact on those. Social isolation, psychiatric illness, what we talked about, functional impairment, where you may think you're a burden. Someone has to take care of me. It's, access to lethal means, and then physical pain. Remember we said pain, especially among men, it's a very high risk factor for suicide, which then leads to lethal suicide behavior. And if you have time, this article is really good. You can download it for free and read a lot more about how they have superimposed this schema over Joyner's interpersonal theory of suicide. Next one. So here are some warning signs. I don't know how many of you work in long-term care settings, or you consult, or my family would be better off without me. I just make things worse for everyone. I can't take it anymore. It'll never get better. What's the point? I wish I could go. I used to hear this very often. I wish I could go to sleep and never get up. You don't need to worry about me anymore. Next. Red flags. I have nothing left to live for. I don't want to be a burden to my family. It doesn't matter. I won't be around much longer. Giving possessions away, putting affairs in order, changing one's will, those are fairly obvious. Failure to take prescribed medication. We get a lot of consults on that in terms of self-neglect. Is this suicidal behavior, or what's driving it? But if you look at all self-neglect cases, the underlying cause is they have a major depression and or cognitive decline. So unless we address those, it's very you really can't make a good assessment about someone not adhering to treatment, saying goodbye. These are acute risk factors. Current intent or plan, method is easily available, whether it's medications or guns or whatever. access to lethal means, severe hopelessness and pessimism, perceived burdensomeness. Remember, I'm a burden, I don't want to live anymore and I don't want to bother my family. Recent diagnosis of a chronic illness. Remember I said the risk increases with the number of chronic illnesses you have. Severe loss of interest or pleasure, which is a symptom of depression. Recent discharge. Did you know 44% of people complete the suicide after being discharged from acute psychiatric hospitalization? That is actually the highest risk point, is post-acute psychiatric hospitalization. So it's up there. Isolation and loneliness. Low or no social support. Recent stressful life event. Next one. Here are the protective factors. Effective clinical care for mental, physical, and substance use disorders. It's more easier said than done, right? Access. Easy access to a variety of clinical interventions and supports. Family and community support, which is that connectedness that I'm talking about, that social connection. What is your social capital in your community? Do you have volunteers who visit? Do you have settings for older adults to come and meet and chat? Do you actually reach out to lonely, isolated seniors? Support from ongoing medical and mental health care professionals in that relation. Skill in problem solving, conflict resolution, and non-violent ways of handling disputes. And lastly, cultural and religious beliefs that discourage suicide and support instincts for self-preservation. There are a lot of religions which actually proscribe suicide. So which is a protective factor. So having, and then just having a faith community in itself is a protective factor. That you have the sense of connection and belonging. Next. Some more personal characteristics. Resilience and perseverance, like what you were saying, Shell, earlier about African American women. To reach 80 years old, or for men to reach 70 years old, that means they're already the cream of the crop, because they have, they've come up the hard way, and really the ones who have mastered resilience reach to 70 or 80 years old. So resilience and perseverance. Openness to experience, not being closed out that I'm not going to try something new, or hey, I'm going to think about something new that my counselor suggested I do. Sense of meaning and purpose. How many of you would be satisfied if you I'm talking if you were older, if you just took your medications, took care of your diabetes, ate your food, and went to bed every day at 9 o'clock? Would that be a meaningful life? But many of us expect that to be a meaningful life for many of our clients, correct? Hey, you're in a nursing facility, your meds are given, you have your shower and you go to sleep at 9 o'clock. And when I ask them, what makes you get up every day? What gives you hope? Those are the critical questions we need to be asking. Because that is actually what actually is a protective factor, if you have a sense of meaning and purpose. Self-esteem. And then positive health practices, and look at it, help-seeking behavior. That means you are willing to ask for help or seek help, which there's a huge gender disparity in health-seeking behavior, that men tend not to seek help, women do seek help. Not just for mental health, for also physical health issues. I have to, on multiple occasions, I have to intervene in my husband's healthcare because he will not seek help. And so I just pick up the phone and call his doctor. he's having this. Why is he not calling? I have no idea why he's not calling. I'm calling for help. So yes, health-seeking behavior behavior is something that you should actually cultivate in your clients, that it's okay to ask for help. Most individuals, look at this sad thing. Most individuals receive health services a year before suicide. The study shows that majority of people who died by suicide receive healthcare services a year prior to their death. Half of them had a medical visit 4 weeks before they killed themselves. 4 weeks. And the most common type of visit was primary care and medical specialty. And they were mostly older adults, specifically women. This is a key opportunity to intervene in primary care settings. And because we have ample time to intervene. But guess what happened? Nobody asked them, how are you feeling? Have you had thoughts about hurting yourself? Up in the primary care setting. Imagine 4 weeks before committing suicide, they were in a doctor's office. And so that's a point of care that we should intervene. And if you all have connections to your local primary care docs, that should be something you should be talking about. If you all have multi-agency or social service meetings, that this is a point for intervention. Yes. So, identify social, so that was all the risk factors. Any questions on the risk factors? Yes.
I think with some of the folks I see, they may be 42, 45, but a lot of the factors you see, their real age, if you...
Chronological, younger,
but
yes.
They're maybe like a 60-year-old.
Yes.
And a 42.
Yes.
Because their life has been so stressed.
Right. Do you know that, people with serious mental illness, what do they die from? Like people say with schizophrenia, bipolar disorder, many of the clients that you serve on ACT teams and stuff. Do you know? Pardon? Did you say something? No, they die from cardiovascular disease. They die from modifiable risk factors like tobacco and obesity. They don't die from suicide, they don't die from psychosis. And another sad fact, they are dying 25 years younger than the general population. Our life expectancy in this room for women is 83, and for men it is 79. And if you have a serious mental illness, you're dying in your 50s. Which is a shocking, I think it's immoral, but that's what's happening. So they're not dying from suicide or from their mental illness, they're dying from cardiovascular disease. Why do you think so? Why are they dying from cardiovascular disease?
We had a presentation a few years back from a primary care doc that was finding well, particularly with women in their 50s, the trauma is...
it is a risk factor for all of these chronic physical illnesses. If you've got that...
with some kind, it could be birth trauma,
yes.
Birth defect, but
right.
more likely some kind of social...
Have you read the ACEs study, Adverse Childhood Experience?
Yes.
But why are these people with serious mental illness dying of cardiovascular disease? You and I are not dying. I know it's a leading cause of death.
Cortisol.
Stress. So what I see is healthcare discrimination.
Absolutely.
That's what I see.
They are considered a cardiometabolic health disparities group. And guess what? Bias. It is provider bias. So you and I get a call from my doctor's office when I turned 50 to have a colonoscopy. It was relentless the way they called me. Yeah. Till I went in. My clients don't get that same kind of dogged, for no, you have to come in. And do you know people with serious mental illness die at high rates from cancer? Do you know why?
Early detection's not there.
Late to diagnosis. Because by the time they get diagnosed, they are at stage 4. Recently, very sad, I was working with another community mental health program in Eastern Oregon, young man, 40. He kept telling people, my stomach is hurting, and everyone was ignoring him. Till he was like rolled over in a fetal position, and then they took him seriously. And he's at stage 4 stomach cancer, with like 3 months to live, and here we were fighting where were we going to send him, and finally we got hospital, but he was late to diagnosis. So it's very sad. So there are so they're dying because our healthcare system is discriminating against them. And that's why we have this whole work about equity, that these people with serious mental illness need also to have the same gold standard for medical care that you and I get. So next time you're advocating for your client, remember that they're not dying from their schizophrenia. It is from medical, physical problems. And that's why this whole trust for integrated behavioral health and medical care, so you integrate it. So identifying suicidal, asking about suicide does not increase risk. That used to be a myth, especially in medical settings, that if you ask someone, that somehow they will go kill themselves or they will increase the risk. No, it does not. Don't be afraid to ask, and I'm just giving you some suggestions. Next one. And if they were to tell you yes, thank you for being honest. I know this can be hard. I'm just giving you some scripts of how to respond. It sounds you're in a lot of pain. I'm sorry you're going through this. And we'll talk about listening and all that. Next one. You may want to ask open-ended questions. How long have you been feeling this way? Will you tell me the story of how you got to this point of feeling suicidal? Can you tell me the day you were feeling most suicidal? What was happening? What did you do to cope? And this all ties into one of our tools, these questions. Next one. So your goal is, the tension is the goal of the person at risk is to end their life, and versus your goal as a helper to keep them alive. And it's that tension. It's really a tug of war. So these are just some mnemonics for people, primarily in primary care and medical settings, to kind of remember how to see the warning signs of suicide, and it is path, warm. That's the mnemonic. So ideation, substance use, purposelessness, that means having no meaning or purpose, anxiety or agitation, trapped, hopelessness, withdrawal, anger, recklessness, mood changes. Which some of this coincide with DSM-5 for depression, by the way. So it's just a mnemonic for medical folks to remember when they're talking to their patient. I mean, it's good for all of us to remember. So is path warm. Next one. And this is for symptoms of depression. It is CE CAMPS. Sleep, interest is decreased, which is anhedonia, guilt, energy is less than usual, concentration is down, appetite. I swear I changed the spelling. It's still showing S, psychomotor agitation. And then last is suicidal ideation. So again, that's another mnemonic. I just added it in there. If you're ever working with medical staff, this is a good tool to way for them to remember to ask those questions. Next one, please. All of you are familiar with the PHQ-9, right?
Yeah.
How many of you use it?
We have to.
ACT has to, right? No, not the others? Oh, everyone does, okay. So, this is called the P4 suicide, and you all have a copy of it. No, you all got a copy of the screener on your table, or maybe Ailey gave it up. So, this is a very good screener to use if your client is endorsing high score for depression or suicide. Then you should do the P4 suicidality screener. And it is, it's coming around, I think so. And it is validated too. And it kind of tells you what to do. Okay, so I just put it here as an assessment tool for you. And you're getting a copy of it. Next one. So if your person, you do the P4 screener and it comes up there at low risk, they only have passive thoughts of death, active suicidal thoughts without a plan, no previous high lethality attempt, absence of psychosis. So these are considered like low risk factors. The next one. Response to low risk will be express concern. Help identify coping strategies. What is it you can do? Activate the support system, which could be you are actually calling and activating the support system. Having a planned follow-up. Hey, I'd like to see you back in 3 days. Call support and then make a referral if you think. So that's considered like low risk on the P4 screener. Next one. Moderate risk, active thoughts with a plan, active thoughts with a previous plan, psychosis or substance use in addition, and lethal means not readily available. I mean, they're thinking of lethal means, but it's not like readily available. Next one, which is moderate risk. What would your response be? To reduce means reduction, to even further reduce how they can get the means. What would you do? What would be a good intervention? How would you reduce means?
Ask about that.
Okay, and so they say yes. What would you do?
Try to get again somewhere else.
Yeah, you would activate the support system. Hey, can you give it to your mother, or could you give it to a friend? Do you know, recent killings in El Paso and all of that? So there's been a lot of talk about these extreme protective, what do they call it?
Red flag laws.
Yeah, red flag laws, where they have a term, extreme protection laws, where you can remove the guns from someone. And Oregon has actually passed the legislation. It is having less of an effect on mass shooting, but a significant impact on suicide. These extreme protection laws, and I think 2 states have actually shown data that through these extreme protection laws, the prevalence of suicide has dropped. A regular PCP or clinician-initiated phone check-ins. Do you all routinely check in with your suicidal patient? And then repeat assessment. That is if you're at moderate risk, or on the P4 screener. High risk. Endorsement of probability, lack of preventive factors or protective factors, and lethal means readily available. Next one. Ask additional questions, don't leave the person alone, and facilitate hospitalization. That would be high risk. Okay? I just included this. I'm not sure how well you can see it on your slides, but this is a great tool for community first responders and all to use. Critical protection strategies for the whole community, where they ask these 4 questions. And it actually identifies also mass, hopefully, people who want to do mass killings. So I just included it. If anyone is interested in actually me just sending it to you by email, just that, because you may not be able to read it and we don't have a handout for it, I'd be happy to send it to you. Great. I actually talk about the CSR, the other tool too. It's coming. Yes. Next one. So you all got the Columbia Suicide Severity Rating Scale. Did we pass it? No, it's right there. We made copies of it. And I'm not going to spend time on it, but regardless, it's a questionnaire used for suicide assessment developed by multiple institutions, including Columbia University with support from NIMH. It is 3 pages long with the initial page focusing on a checklist. How many of you are using the...
It's in our EMR.
Okay.
Yeah, so it's a routine thing.
Correct, routine. But if anyone wants additional training, it's free to get there. And I'm sure who all are using it have been trained, but I'm sending it around as one of the assessment tools. Okay? So next one. So, how many of you do know suicide contracts? No evidence that it works. Yeah, safety. I'm talking about no suicide contract. I promise I will not hurt myself. I will call you if I'm feeling so. Those were, the suicide contracts. We are saying, get rid of that. Next one. No suicide contract versus safety planning. And we're going to talk about safety planning. A no suicide contract takes the form of asking the client to promise not to kill themselves and to contact professionals during a time of crisis. There is no empirical evidence that supports the effectiveness of no suicide contracts for preventing suicidal behavior. There is really no empirical evidence. Next one. So what we are, do you all also have, Sharon, safety planning in your chart?
Yeah, safety plan.
And all of you use safety planning? Okay. So and we've passed around the template. Some of you who may not be from class of healthcare, you can take a look at that. A safety plan is a brief intervention that can significantly reduce suicide attempts. Rather than telling the person what not to do, that means don't kill yourself, you're promising. The plan helps the person know what they can do to feel better and stay safe. So it's more empowering. It builds self-efficacy and empowers the person. Hey, I can cope with it. And in a way, then you're promoting or giving hope, which is what you want to do. Next one. Safety planning intervention. Brief intervention, and you all are actually doing it, so you probably know it really well. It takes 20 to 45 minutes. Provides clients with a prioritized and specific set of coping strategies and sources of support that can be used during when suicidal thoughts emerge. And the intent is to lower imminent risk by consulting a predetermined set of coping strategies and a list of individuals and agencies to contact. Unlike a contract, a safety contract. It doesn't give you any coping strategies, it just says don't kill yourself. And call when you're in a suicidal crisis. Next one. Components of the safety plan, I know, and I may be preaching to the choir for some of you, but there are some individuals here who don't use it, so this is good information. So what are the components? It helps the person recognize the warning signs of suicidal crisis. Employs internal coping strategies. Utilizes social contacts as a means of distraction from suicidal thoughts. Contact family members or friends who may help resolve the suicidal crisis. Remember, we talked about help-seeking behavior is an asset. Contact mental health professionals or an agency. This is a hierarchy, okay? And reduce the potential use of lethal means. These are the components of safety planning. Next one. And here is how it looks like, and you actually got the template. You have the template. So you will work collaboratively with your client to come up with 3 warning signs that a crisis may be developing. What are your thoughts, images, mood, situation, behavior? 3 internal coping strategies. Things I can do to take my mind off the problem without contacting another person. That means I can do it myself. It could be a physical activity, it could be a relaxation exercise. I know one person said, I have to go and drink coffee in Starbucks, I feel safe there, I'm with other people. That was their internal coping strategy. Third is people and social settings that provide distraction. What can you do? Go to the library and sit and read a book in the library. Could be one. People whom I can ask for help. That means not professionals, just your circle of friends. Professionals or agencies I can contact during a crisis. Making my environment safe. And lastly, the one thing that is most important to me and worth living for. I had a friend who was chronically suicidal. She said it's her dog, her little dog, who she had for 15 years. She said, that's my reason for getting up every day and staying alive. And she wrote that down there. And so this is the safety plan, and you all have a template for it, and you all actually have it in your EHR apparently, so yes. So why does means matter? Remember, white males, one of the highest prevalence rates because they use lethal means. And actually men in general across all age groups. Suicidal crises are often brief, especially in younger adults, not so much in older adults. The deadliness of an attempt depends in part on the method used. You know, guns are fairly final if you put it in your mouth, correct? There's no ambivalence about it. 90% of those who attempt and survive don't go on to kill themselves. That's significant. That means they attempted suicide, but they went on never to try it again. So, how important it is to intervene. Yes. Was there, could you just back one? Did I miss? Oh, sorry. Means restriction, that's part of the safety planning. Remember the environment, make my environment safe. That's part of the safety planning template. The risk for suicide is amplified when clients report a specific plan that involves readily available method. That if you have real easy access to guns, the risk is amplified. And you as a clinician should be at high alert. And do you know what? As we go more rural in Oregon, suicide rates increase. And the one, among many other factors, one reason is gun ownership. There are many other reasons, you know. As we go rural, the population actually ages. They grow older. They have multiple chronic illnesses and poor access to healthcare services. I mean, it's a, you know, it's a nexus of all of these factors, but gun ownership is one of the reasons. So yes, it amplifies the risk. So this is considered rural. So if you know if your client is suicidal, expressing suicidal ideation and has a gun, you should absolutely focus on means restriction. Key component in the safety plan intervention involves eliminating or limiting access to any lethal means in the environment. Safely storing medications, implementing firearm safety, restricting access to knives. Do you know, by the way, SSRIs and NSRIs, you know, the second generation antidepressant medications, they are not lethal in overdose. Unlike the first generation antidepressants, they are lethal in overdose. So yes, keeping medication safely is as effective. You should be doing it as much as you would do with guns, because women use medication. We are listing it as poisoning, but it's really medication overdose. Next one. Look at what are some effective treatment and therapies. Brief intervention, and you'll be surprised. One is the safety planning, which we just did. Follow-up supportive phone calls and postcards. How many of you send a postcard? I mean, I know you all have more of a long-term relationship with your clients, maybe not so much in mobile crisis, but some of your other groups. But this is one of the most effective interventions, and I'll show you the citation later, especially in EDs and hospitals, if you send a postcard to someone. CBT, dialectic behavior therapy, reduces suicidal behavior in adolescents and in adults with borderline personality disorder. Do you all offer DBT? Okay. Look at clozapine. Today, this is the only medication with a specific FDA indication for reducing risk of suicide or suicidal behavior in patients with schizophrenia and schizoaffective disorder. So it's clozapine. And the only medication with FDA approval. Next one. Here, follow-up. Sending a caring text or card to say you are thinking about the person could be a life-saving intervention on its own. Use of postcard reduce suicide attempts and deaths and slightly reduce healthcare costs. And this was published in the Psychiatric Services Journal. They did a random control trial. Telephone outreach 1 to 3 months after discharge, hospital staff call patients to offer support and encourage engagement and follow-up. So if any of you are working with your local hospital, this should be part of your zero suicide protocol. Hey, let's institute sending a postcard. let's do the follow-up phone call 1 to 3 months later. And then, of course, cognitive behavioral therapy. Next one. Again, just a word on that. I already told you about clozapine. Look at that strong evidence in patients with reoccurring bipolar disorder and depressive disorder, long-term maintenance treatment with lithium salt, major reductions in risk of both suicide and suicide attempts. So in people who have chronic suicidal ideation, lithium is very effective. And then, do you know the latest drug which has been approved by FDA as of March 2019? That, right there. Esketamine. Ketamine, intranasal formulation. It was FDA approved for treatment-resistant depression, and they're about to also make it FDA approved for suicidal ideation and suicide. I mean, there's a remarkable turnaround with esketamine. So, any of you are thinking of your patients who have refractory depression or chronically suicidal, you'll have tried everything, including clozapine. This could be something to consider talking to your, whoever the prescriber is. Next one. Why, and I know you all work with the local ED here, right? Emergency room. Why address suicide prevention in the emergency department? The risk of suicide attempt or death is highest within 30 days of discharge from an ED or an inpatient unit. I said 44% go on to commit suicide after discharge from inpatient. Up to 70% of patients who leave the ED after a suicide attempt never attend their first outpatient appointment. Do you all have a protocol for that? You all do outreach, phone call, and good. Approximately 37% of individuals without a mental health or substance use problem who died by suicide made an ED visit within a year of their death. Imagine, almost 40% went to the ED but did not follow through or whatever happened, and they actually died by suicide. How can emergency departments help prevent suicide? These are some things: brief patient education, helping the patient understand their condition and treatment options, safety planning, the template that we went through, lethal means counseling, assess the patient's access to firearms, prescription and over-the-counter medication and other lethal means, rapid referral, schedule a follow-up outpatient mental health appointment for the patient, ideally within 24 hours. I know that can be a challenge. And the caring contacts that I talked about, postcards, phone calls, emails, and text messages. This has already been proved through random control trial that they are very effective, the postcards and the phone calls. Next one. So prevention is key. So I just want very briefly, so there's universal prevention, where we focus on the entire population at risk. And that's why I gave you all that prevalence data at the beginning. What I'm saying is, we should be looking at the entire older adult population, which I said in your county, 22%. Very soon it will be 1 in 4 adults in your community will be an older adult. So you kind of surveil the entire population. Depression screening, education on factors associated with risk, education on suicide prevention, limit access to means. So how many of you are doing community education, or you all have those, what are they called, CHIPs, those community health improvement plans? Is this something that has been included in it? How can we prevent suicide for older adults? Because you do have a large older adult population. So even just providing education on what are the factors associated with both depression and increased suicide risk. Then you do, that is universal prevention. Then there is selective prevention, where you target individuals at increased risk, but who may not display suicidal thoughts or behaviors, such as experiencing life transitions. Here you would focus on reducing disability, enhancing independence, increased provider awareness, like their PCP's awareness about, what are risk factors. For example, someone who loses their driver's license, address social isolation. One way we are addressing social isolation through our initiative, and Ailey can tell, I don't know whether you have those cards, your peer online cards. One is we are doing phone calls by peers who are trained in older adult behavioral health to mitigate social isolation. So they get a phone call from a trained peer who engages them socially and also provides support. If you have not heard of that, please contact Alien. Please make referrals to that line. So that would be a selective prevention strategy, or educating your primary care physicians. I just told you 4 weeks before someone completes suicide, they saw someone in a primary care setting. Did they get screened for suicide? Do the medical providers know what are high risk factors? Are they aware that they should be asking about lethal means? Those would be all selective prevention. And the next one. The last is indicated prevention. Efforts aim to prevent suicide at those who are at the highest risk. Someone who already has a depression, multiple chronic illnesses, has experienced losses or family discord, those all would have access to lethal means. Detection and effective treatment of depression are keys to reducing suicide. So routine screening for depression using the PHQ-9 or the geriatric depression scale. Implement practice guidelines for detection and management of suicide in late life. So do you do like stepped care for depression in your settings?
What do you mean by that? Stepped care?
Stepped care, so supposing someone has this high score on PHQ-9, you go through various stepped care, which would be medication management, referral to, say, the evidence-based practices for older adults is problem-solving therapy and behavioral activation. You have a care manager who actually monitors progress and reports it. And the model is called Impact model, which is stepped care for depression. So it is highly recommended, especially for older adults, in integrated settings. Do you provide bidirectional primary care in your mental health settings?
Do we have collaborations? Yes. And we communicate. We have monthly case management meetings with the FQHC. We do a lot of communication, but I don't think it's that formal. It's not formalized in a way that you're talking about.
So you don't have like a primary care provider in your mental health clinic?
Oh, no.
Okay.
That's a dream that we have when we're building, to have all this together with the FQHC.
So where is your FQHC? Which city in Claxon?
Astoria. It's in
Oh, Astoria. So not too far.
Yeah,
We're really close to each other.
everything here is pretty close.
Okay.
Except for Napa.
So what percentage would you say are older adults in the FQHC? Any idea? Like older adults, I mean 60 plus. Any idea, like in terms of their patients, how many are?
They don't really serve very many children, I know that.
Okay.
I don't know how many older adults they have.
Okay. Okay. Next one. So here are some prevention strategies. Prioritization of suicide across all levels of care. Nursing homes, EDs, primary care offices, FQHC, community mental health, even senior centers. You can train anyone to do a screening. APD offices, AAA or ADRC. Effective identification and assessment strategy, and that's why I gave all those tools. And the risk factors. How do you identify someone at risk? Older or younger, Comprehensive surveillance systems and outcome tracking, which is that population health. You know older adults are at risk. Then you kind of narrow it down who's at highest risk, and you surveil them regularly. You screen them and you're watching them. Large registries linking risk across systems and providers. Do you use disease registries at all?
The CCM might,
Okay.
here Oregon, but they're much more like embedded with that kind of thing.
Okay. Do you use disease registries for your mental health clients? I just told you that people with serious mental illness are dying from diabetes and cardiovascular disease. It's very good to keep a disease registry because then you can stratify by risk, who's at the highest risk, and then you actually do an analysis of the data on a regular basis. Hey, did they get their labs, their regular A1C checkups? Their A1C is very high, their risk is very high. So disease registries are very, very helpful, and they're actually quite easy to create through your EHR. I did that work for Clackamas County. I actually created disease registries for diabetes and hypertension. Yes. Enhanced electronic medical records with real-time notification, like you're saying, we coordinate very closely with the FQHC. Care coordination between multiple providers, departments, and systems. And I think you said you'll have some did you say monthly meeting or weekly meeting?
A monthly clinical meeting and a monthly administrative meeting with the FQHC.
Okay. What about do you all collaborate on complex cases that have kind of these risk factors? Okay.
One of the risk factors is not only contact with medical professionals, but law enforcement.
Yes.
So that I've seen a real improvement with getting reports from
Absolutely.
contact with the police. They're seeing more mentally ill folks than we are.
Right.
But that's certainly
Absolutely.
And the other thing, I know this is a whole other presentation, but the co-occurring homicidal ideation, we make a safety plan. Usually if it's homicidal ideation, they aren't getting a safety plan, they're going to a hospital somewhere or to jail. But depending on the severity, of course.
Right, right.
And that's a physician's decision, not ours. But is there co-occurring evidence related to people with suicidal also being homicidal? You mentioned about folks that want to go out, kill somebody, then they're planning on killing themselves, but they want to take out.
So not in the sense of older, not in the sense of mass killing, it's really spousal, So they kill their wife and then they kill themselves.
Right.
Very often they are frail, they are unable to take care of each other, and they are afraid of getting more dependent. So whoever is the more healthier spouse, it's like what's it called? Homicide-suicide pact. And it's actually growing steadily, the number. Often one of the spouse has severe dementia. So that's the suicide. It's not very high in older adults, this risk group. Just because they have fairly, they're frail, they're debilitated, they have disability or ADL or, dependent, this group that I'm speaking of. But yes, they have the suicide-homicide pact. And it's growing.
Not just the pact, but those who are wanting angry, homicidal.
No, what I'm saying, it's not a huge public health issue with this group.
Yes.
It's more so with younger males, who are teenagers or early 20s. If you look at all the mass shootings that we've had, it's generally disenchanted young men, if you see, mostly. I've not heard of any woman or young girl going on these streets, which is very sad. And often they make it a mental health problem, but I think it's really multifactorial. It's very simple to blame mental health and then, kind of perpetuate that stereotype that people with mental illness are dangerous, which is false. So.
I'm just finding seeing folks almost have to remind myself to also ask, are you thinking of hurting anybody else?
Oh, absolutely. As a mental health professional, I would stand
It wasn't mentioned anywhere in here, but...
Yes. Because my talk was basically focusing on suicide, but no, I would, when I was a clinician, I would write in there too about homicidal ideation. Yeah. Okay. And then it is effective interventions using existing and alternative approaches, which we talked about, DBT, CBT, medications, connection to social, kind of mitigating social isolation, all of that. Informed care pathways, stepped care treatment approaches, which I was talking about, and then critical treatment engagement. Many people don't make it from the ED discharge to their appointment, and they fall, for whatever reasons, few months later, they do complete and kill themselves. So, next one. And this is just a proposed pathway. I've had my citation there. It's actually from NIMH. Need for suicide care, look at it. Accurate assessment and identification, the first circle. Then, all care providers able to assess and manage suicidal patients or refer. So it's not only QMHPs or ACT staff, everyone should be trained. It is a public health crisis, suicide, in the United States. And it's a 10-leading cause. So it's not a small problem. So we should be training everyone. In fact, I didn't bring it, but I have a script for telephone, the receptionist. How the receptionist should be keeping her ears open or his ears open to hear, and what the receptionist should be doing. So everyone should be able to assess. Enter into stepped care. Effective interventions with multiple access points to care. In-person, telephonic, video, interactive. Do you all use telemental health? For quite a bit?
Just for psychiatry right now.
Okay. But your may expand it?
We have talked about that, yes. I think Care Oregon really wants us to. So.
Okay. Yeah, so multiple interventions. Correct. And I would say even in non-mental health settings, such as the ADRC, senior centers, meal sites, wherever, Care management across all service settings. Engagement strategies, care coordination, risk monitoring, which is very good in that disease registry model because you stratify by risk. The people at the highest risk are on top of your registry, so you're monitoring them much closely. Continuous step care and mental health services, all of this will reduce suicide attempts and deaths. So it has to be kind of like a holistic approach. Next one. Preventing suicide, and if you can download that, it's free to download, it's really great. It's a whole, like a booklet. Strengthen, this is not only for older adults, it's for your community at large, for all suicide. Strengthen economic supports, strengthen household financial security, housing stabilization. How many of you heard of the suicides of despair? Okay. I would suggest you Google this study by two Princeton professors, Deaton and Case, D-A-T-N and Case. They were just looking at big data, and then they saw something remarkable. They saw a dip in our life expectancy. That means life expectancy dropped. And when they looked closer, they saw that in the Midwest, middle-aged men and women were killing themselves in large numbers, so much so that it was affecting overall life expectancy. Many of them were by opioids or it was by alcohol and other drugs. But huge numbers, and they were all under age 64, only with a high school education or below. Many of them unemployed because they had lost their jobs to globalization and had not been able to retool and reskill themselves for other jobs. They were killing them. That's why it's called the suicide deaths of despair. And for the very first time, it actually affected life expectancy. But it's a wonderful study to read. And so strengthen economic supports. Strengthen household financial security. Look at the other one. Strengthen access and delivery to suicide care, which is what we're talking about today. Do you have an evidence-based suicide care package that your agency or your community mental health program is promoting and training everyone in? Coverage of mental health insurance policies. We talk about parity, but really in reality there is not much parity, especially in Medicare. They don't reimburse the same as for physical health and mental health, though it's by law you have to. Reduce provider shortage, and you all are a professional shortage area. How are you addressing professional shortage?
Increasing salaries.
That's one way. How else? Pardon? Telepsych. What else? Have you thought about really developing a non-traditional workforce? You know, you have a huge social capital in all these communities of volunteers and community health workers, by the way, who are delivering evidence-based depression treatment all across Africa and Asia. They're called lay counselors. And I'm hoping to bring that program to Oregon. We were talking earlier, it's called the Friendship Bench is one of them, which is out of Zimbabwe, where he trained grandmothers to deliver problem-solving therapy. So have you considered that? That can we think outside the box and train lay counselors who are supervised by a clinician, but it closes the treatment gap. So really thinking outside the box, thinking about outreach models, which is what older adults want. They don't come to the clinic for various reasons. How can we go where they are? Can we provide, say, a depression class in the local senior center or the ADRC office? Can we take space there and provide depression care, a depression class? And I think Ailey and I are going to explore it along with our partners here. Can we provide depression care in non-traditional or familiar social networks for seniors? Because they don't like coming to specialty behavioral health. Create protective environments, reduce access to lethal means, community-based policies to reduce excessive alcohol use. That's very high comorbidity for younger people who commit suicide, is substance use. Not so much for older, but it's growing with the newer cohort of older adults. Promote connectedness, community engagement. How many of you on ACT teams and other mental health programs, how many of you promote connectedness as a treatment goal? How do you do that?
We have a lot of groups and we try to get them, we take them places a lot of times.
Okay. Okay.
Trying to engage them in the community.
Okay.
They've supported employment.
Uh-huh.
Which is really important.
Mm-hmm. Okay. Teaching, by the way, social isolation mortality is equal to smoking 1 pack of cigarettes a day. That means people die from social isolation at the same rate as tobacco. And if you're interested in the research, any of you, my email is at the end, I will send it to you. That's why our initiative, of which Ailey is a part, we have made social isolation a key part of our health and wellness promotion efforts. And, it sounds kind of, whoa, really? There's a huge amount of neurobiology and neuroendocrinology of loneliness. Why are people dying? Which is really the activation of the stress response and all of that. But yes, you die at very high rates from social isolation and loneliness. Teach coping and problem skills, especially to school-age children. School. I'm not saying we should also teach it to older adults. In fact, that is the evidence-based practice. It's derived from CBT, which is problem-solving therapy. Is one of the evidence-based practices for depression treatment for older adults. Emotional and social and emotional learning, parenting skills and family relationships. So creating strong families. And identify and support people at risk. Gatekeeper training, crisis intervention, treatment of people at risk, treatment to prevent reattempts. These are all some things you can do in your community to prevent suicide. Next one. Do any of you gone through post-pension training? Do you all provide post-pension to? Okay. So every person who dies by suicide leaves behind survivors, right? Who are profoundly affected by the suicide. I personally, my best friend's son committed suicide at age 16. And for the rest of her life, she never got over it. My friend. So it profoundly affects people who are left behind. Survivors experience complex reaction, and I can vouch that my friend felt all of this guilt, shame, grief, all of that. Post-pension refers to programs or interventions for survivors. That means not survivors of suicide, but family members, friends, following a death by suicide. And this was a term coined by Dr. Edward Chapman. So we are really promoting post-pension training in a big way. So if any of your managers, if you are interested, you should explore it with Megan Crane, who is the suicide prevention coordinator for the state. That they offer post-pension training. So it's good to have 1 or 2 staff trained in post-pension. Next one. Risk assessment, why do it? Remember we talked about we all as clinicians do it. Good clinical care identifies individuals at risk, and therefore we can provide more effective interventions. Good clinical care leads to lower likelihoods of lawsuits and sanctions. Hey, we need to be honest here. Yes. Next one. Prediction risk documentation. Risk is something that can be assessed and documented. How many of you write really good progress notes when you're doing a suicide risk assessment?
Crisis team does.
Critical. The absence of a risk assessment in the chart is a liability. The presence of a risk assessment in the chart is an asset. So, bottom line, write good risk assessments. Put in everything, what the risk factors are, what the protective factors are, how you came to the conclusion of the level of risk. And then I did these interventions. Yes. Next one. I've just put some resources here for you. 5 action steps for helping someone in emotional pain. Ask. And there's actually, are you thinking about killing yourself? Keep them safe, that means reduce the means. Be there, listen, care. Recently there was a show on CNN where they visited with this man who jumped off the, Golden Gate Bridge and survived. But they were revisiting him after 10 years. And you know what he said? He said, I would not have jumped off the bridge if even one person had stopped and asked me, how are you feeling? He said, I was crying and nobody stopped and asked me. And he was in the bus, he took the public transportation, he was in a bus crying, he got up, he was walking on the street sobbing, he went to the bridge, but he said, nobody stopped and asked me. That was pretty shocking to me. So just listening and asking. Help them connect, and this is the national number, that 1-800. If you don't, you can give your crisis line and the national number, and stay connected. Follow up and stay in touch after a crisis. And I've given you all the evidence for postcards and phone calls and all of that. Next one, please. This is a fabulous resource which is free for you from Centra. Treatment of depression in older adults. And remember, I said 97% of older adults who complete suicide have a psychiatric illness, most often a major depression. So this is a very good toolkit. Next one. Here are a ton of resources which are very helpful. I know I told Amy, what was the man one? That mantherapy.org? You may want to go there. It's really interesting. Because, men are now considered a mental health disparities group because they don't seek help. No, they don't seek help. So how do you increase help-seeking behavior? And they have some very good tips, this mantherapy.org. Next one. This one is very good, a technical package of policy programs and practices. And then Zero Suicide Institute. How many of you are familiar with the Zero Suicide Initiative? Some are, okay. You should, it really looks at large systems of care. How can we make suicide like a zero suicide? That's our metric, that means no suicides. Yes. And it's some really good stuff. So if you go to this institute, there are lots of free stuff to download, videos, training materials at this Zero Suicide Institute. Next one. And I have my phone number and my email is there. If you would like any material that I referred to, which I did not hand out, like the study from Deaton and Case, or about smoking and loneliness and mortality rates, I'd be very happy to email it to you because we were limited on how much we could print. I know the citations may be very tiny at the bottom of your slides, but if there's some burning desire to get one of those resources, just write to me and say slide number 3, I can't read the citation. I'll be happy to send it to you. And we have a few minutes for some questions or comments or sharing.
Did you send the PowerPoint out to?
I have it.
Yes.
So Jenny will send, you'll send it out?
So everybody that came, I can send you out the PowerPoint on email. Good. So I'll just take a copy of the list.
Oh, then you'll be able to see the citations. Because they're all there.
Right.
And all of them are in the public domain, free for you to download. Any other questions? I have a question for our APD and AAA partners. What do you do for your consumers who may be expressing depression or even suicidal thoughts?
We actually have a form that needs to be filled out while we're on the phone with the person, and if our manager's there, we refer it to her, and she runs it through to the proper authorities.
Okay.
I've done sheriff checks,
Okay.
checks.
Okay.
And we also have the Senior Care Mentor Program, the evidence-based. So
The HOPE program?
the whole program.
So how many, do you all know about the HOPE
We don't
program?
have very many. We only have one volunteer in our county, so we need to find more volunteers. But we only have technically only a focus on the program. We have about 3 screenings in, but it's a program we need to get out there more and get more.
Absolutely. And our initiative is all about enhancing the infrastructure that already exists. So I'm hoping Ailey and we all can work with actually, maybe highlighting this program and increasing the referral once you have maybe 2 or 3 more volunteers.
It's not for, I'm sure you're aware of it, it's not for people with severe anxiety,
Right.
severe depression.
Right.
But that middle population that we're missing out on that can become that way.
Right. I would highly recommend if you want to engage or collaborate with Clatsop Healthcare, to see if they have, some way of collaborating with you. But it's a homegrown program which they adopted from Scotland. It's CBT from it's a manualized treatment from Scotland, and it was peer reviewed and published in a journal, so it's right in your backyard. I don't know what HOPE stands for. It's an acronym, I know. Do you know what it stands for?
I don't, I have it, I'm writing the brochure back there.
Okay.
It's called Senior Care Mentoring, but yeah, it also says HOPE on it.
Yes. Any other questions?
It's out there too, if anybody wants to know.
I'm hoping this was helpful. It was kind of narrowed to older adults, but I think there were things in it which you could also use across the lifespan. But that's my area of work and the work that the initiative does, so we kind of kept it narrowed to older adults. And I welcome any, contacting me if you have any questions. And again, thank you for inviting me, and hopefully I'll come back someday. Thank you.